Allergy and Asthma Network is very concerned about disparities we see in asthma care. Through our programs, like Trusted Messengers and Black People Like Me, we work tirelessly to end the needless death and suffering due to asthma, allergies, and related conditions. We do this through a four-pronged approach of outreach, education, advocacy, and research. My name is Sally Schessler, and I'm Director of Education for Allergy and Asthma Network. Today, we'll be looking at recognizing disparities and addressing them in asthma care. We are joined by Dr. Michael Bowman. Dr. Bowman is a retired pediatric pulmonologist who finished his work at the Medical University of South Carolina in 2016. He came to MUSC in 2000 to establish the Children's Lung Center. Always an academic physician, he has excelled in patient care, teaching, and research, and is now a professor emeritus at MUSC. His recent clinical focus has been asthma, especially in the underserved and solving challenges for schools. Now retired, he's a member of the board of directors of Allergy and Asthma Network, where he focuses on teaching, advocacy, and working to improve care among minorities. Dr. Bowman, we're so happy to have you with us today, and we look forward to what you have to say.
Thank you very much, Sally. It's a great pleasure to be here. And my email is on the slide, and you are very welcome to email me any questions or comments or suggestions that you may have after the program. So being a dutiful speaker, I need to make disclosures that I really don't have any conflicts that relate to this discussion. It's important to realize, and we'll talk about formularies a little bit, that asthma medications are often used for children off-label. If I'm not mistaken, the label for albuterol only goes down to age 3, and so we very definitely use things off-label. The learning objectives for today include identifying barriers to asthma control in underserved populations. And by underserved populations, I mean folks in inner cities, also rural populations, and very often minority ethnic populations as well. It's important to understand the impact of social determinants of health on asthma care. We'll talk more about that a lot. I need to identify ways to utilize effective communication patterns in all asthma teaching situations, and especially when you're dealing with folks who aren't confident in the English language or have not done super well in school. You may need to do different things, but that's an important part of how we function. You need to be able to identify support services needed to optimize asthma control for underserved, because we have what we call deserts in the inner cities that are very important. Sorry about that. Let's see here. And then we will identify support services as well. So the asthma burden, the incidence varies among ethnic groups. There are marked disparities in outcomes in terms of ER visits, admissions, and deaths. Multiple social factors make asthma more difficult to control, and these have to be recognized and addressed. If it were easy to fix them, they would have been fixed long ago, so we still have those challenges going forward. Overall, asthma is estimated to cost over $80 billion a year in the United States, and while that is very small compared to $3 trillion federal programs right now, it's still a huge amount of money spent to try to control asthma. Underserved populations need extra assistance in a variety of settings that we'll talk about, and the access to healthcare is required to make the diagnosis. So that's a fundamental part of where we even start in this discussion. Now, this is a cartoon that I found related to health equity, and there's the reality where some people are really well off and really able to see over the fence. Some just barely make it with what they've got, and others have nothing and are actually worse off. In the situation of equality, everybody, no matter what, gets the same benefit from the same supports. And this leaves some people very much out of the picture. equity instead of equality. Equity means that each group gets the support that they need in order to succeed. So some folks may not need any additional support, some need a little, some need a lot. And then if we were to really look for justice, there wouldn't be the barriers to effective outcomes at all. But anyway, it's important to realize the difference between equality, reality, equality, and equity. It's important to start understanding the incidence, and this is the latest data that I could find concerning the asthma incidence. So in white non-Hispanics, it's about 8%, slightly less in children, slightly more in adults. No tobacco use data was recorded in this group. Among Blacks, it's higher, and in children, it's twice as much. So that's important to recognize, and in some places, it's even worse. In some inner cities, it may be as high as 20%. So that's an ongoing problem, and that's the core reason for discussion of things today. Among Hispanics, overall, it's not that different from the white population. However, among Puerto Ricans, it's markedly worse than the white population. So that's an important difference. Not all Hispanics are the same. Those with a Mexican background may be actually better off than the white population. Very similar among children. So that's something to pay attention to. And then when we look at Native Americans and Alaskan populations, they're high as well, not quite as high among children as Blacks, but they're high across the board. Asians, for some reason, have lower incidences. And then multiracial non-Hispanic are again closer to the Black population in terms of incidence. And this is a very good setting for reference for this data, and it is improved every year, so you can follow that as you go along. So, excuse me there. So, sorry to have tapped that one. Anyway, the asthma incidence versus poverty is also a key thing that we pay attention to. For all, again, it's about 7%. In children, it's slightly lower. In adults from this data, it's slightly higher. But according to the poverty level, there's a difference. Using Census Bureau standards for the poverty threshold, if you're below the poverty threshold, you wind up having a 30% increase in the likelihood of having asthma. If you're between 1 and 2.5 times the poverty threshold, that goes down. It's still not down to the baseline overall average, but it's better. And when you look at the 2.5 to 5 times the poverty threshold, it gets down actually to slightly below the frequency for all the population. So again, that is something I couldn't find. I tried very hard to find a set of data for example, Black population in poverty, and I couldn't find what the numbers show. So that's, looking at them individually, they both show problems for the population we're talking about today, but when they're put together, when you get a real double whammy, I don't know exactly what the numbers are. And then when you're above 4.5 times, you're really better off. And that goes with living in the suburbs and a variety of other things. So triggers, as you know, are important. So allergic triggers include nose, skin, eyes, lungs, and it's important to assess the child and the home and the school for triggers of allergies. They may be trees, pet dander, dust mites, mold, pollen, cockroaches. You have it, but they're very individualized. So there is not an automatic for every child a requirement that you get rid of the dog. If the child is allergic to dogs, then you need to get rid of them. But if you don't have that situation, you don't need to do that. There are non-allergic or intrinsic problems such as viral illnesses, aspiration, GE reflux, and obesity that can trigger problems. There are irritants that are just generalized. They don't require an allergy. That includes diesel exhaust. That's why there are many programs that prohibit school buses from idling on school grounds. Cigarette smoke, scents can be a problem. Use of body scents can. I had a patient some years ago who had problems for 3 months after school started with her asthma and even needing prednisone. And it wasn't until November that we realized the girl next to her liked body spray. And so when we put the girl with a body spray in the opposite corner of the room from our patient did much better. Exercise, there's exercise-induced bronchospasm, and I feel it is more common among kids to have asthma triggered by exercise. We'll talk more about that. And I feel that it's important that kids should generally not get albuterol before recess or PE. If they seem to need that, chances are good there are enough symptoms other times that haven't been recognized that they should be on controllers. We expect full normal exercise in sports for our patients across the board. So in terms of recognizing asthma triggers, what has been seen in history? Does it occur with seasons, activities, locations? Does it go with nasal discharge and that sort of thing? In testing for allergen responses, IgE blood testing, both total and specific for individual allergens, can be important. Skin testing, eosinophil levels can be helpful. Irritant exposures, do they affect the child? Does the child come home from the state fair after being in hay all day, coughing and wheezing? Or do they have problems when they're around a fire pit at night? Those sorts of things can be a trigger. And then what happens when they play hard? And has albuterol ever reduced or prevented those symptoms? That's a very strong marker that they have exercise-triggered asthma or asthma that is triggered by exercise. Colds, you want to know the symptoms, the duration, and the treatments. We frequently see youngsters who come in for a new consult that the family will say, oh, colds hit her hard. She's sick for 2 weeks. She needs to get prednisone and an antibiotic, and she really has problems. So we expect colds that aren't carrying into an asthma flare to be 3 days, 5 days, something like that. And it's definitely a major worry sign to have colds that always last 2 weeks. If you have nocturnal symptoms, think of esophageal reflux, and the environment is the child sleeping with a dog. Do they have a horribly old mattress, that sort of thing. What about comorbidities? These are conditions that can worsen asthma if they're not controlled. So allergies are a comorbidity that we need to pay attention to. Sinus disease is one of those. Obesity can be a problem, and that in and of itself makes exercise more challenging. GE reflux should be considered, and one thing to look for is nocturnal symptoms, and I would ask families if the child has bad breath in the morning, and not infrequently folks would call it kitty litter breath or dumpster breath. And then when you treat the reflux, lo and behold, the asthma symptoms get much better. Aspiration can be from above or below. It can go along with reflux. Kids can have swallowing discoordination, so that can be a problem that's not recognized. So we need to identify and treat these problems to optimize the asthma control, no matter what we're doing in terms of controllers or just rescue medicines. So allergic recognition and trigger is assessment. Allergic symptoms are more likely cough versus wheeze. And I say that meaning that a lot of youngsters get a junky nose and they cough, whereas when they wheeze, that may be the asthma that goes along with the allergies. And so you very often get simultaneous problems, and you need to go with what you have, but don't assume that asthma is an allergic condition, because it's not. You can get it from a lot of other things. We want to avoid any problems, and skin testing and IgE immunocap testing are recommended for anyone who has persistent asthma. Immunotherapy is increasingly available, only used when you have significant symptoms, and it's really a major commitment by the family, and they frequently don't recognize the degree the child may have needle phobia. Treatment of upper airway disease symptoms is important to pay attention to. And then the role of consultants. I say that because 70 to 80% of patients with asthma are cared for by primary care providers. And so I think each PCP has their guideline as to when they refer to a pulmonologist or an allergist, but those specialists may not reside in the inner city, so there may be more difficult access to those consultants. Asthma risk is the question, how likely is an adverse outcome? And it's based on history, and higher risk suggests need for stronger treatment and really looking hard for triggers. It includes hospitalizations, intubations, and steroid courses. And it's not uncommon these days for when you're talking to a new patient to ask how many steroid courses has he or she had. Oh, 6 or 7 in the last year. And you really wonder who's counting. And especially with fragmented care where they'll go to an ER or their primary care clinic or something like that, there may not be any single physician or nurse who is counting up the total number of steroid courses. Prevention is the key, and recognize that somewhere around 20% or so of patients with asthma can't perceive dyspnea. They cough and they wheeze, but they don't feel short of breath, and they're at higher risk for bad outcomes. And remember that asthma deaths actually come from all classes. So even patients with intermittent asthma have the risk of dying in the bad situation. Now, racial ethnic disparities are related to the social determinants of health, and that includes neighborhood and environment, health and healthcare, social and community context, education, and economic stability. And the asthma incidence and outcomes vary greatly, and it's sometimes difficult to separate the biology and the triggers and the comorbidities versus social disparities. It's important to try to get into those weeds as far as you can to be specific, because we need individualized approaches for everybody. And the family has to provide the care prescribed. So education and understanding are crucial. That's going to be a recurring theme through the rest of the talk. We can't fix everything, but addressing the barriers helps. And we need to coach every patient and family for best outcome, and recognize that when they become preteens and teens, these conditions are going to be the responsibility of the youngster rather than the parent. So factors contributing to disparities include, on the individual level, genetics, socioeconomic status, indoor pollutants, tobacco smoke, vitamin D status may play a role. That's been plus and minus in terms of data. Violence and stress, access and delivery of healthcare, literacy and culture beliefs, what grandma says, can be very important. And then at the community level, again, socioeconomic status, housing conditions, socioculture factors, who does the child hang around with? Are they in conditions of violence and stress? Are there outdoor pollutants? And what education is available to both the caregivers and the patients? So this is a very good reference for you to take a look at these factors. In terms of public housing, it's problematic, but it's variable because now they're more decentralized. Common problems include poverty, rental properties. They have to use more of their income for housing. It's important to realize that just recently HUD started or initiated the policy totally across the board of smoke-free housing units. So any housing and urban development setup is a non-smoking area now. Mold, dust, and cockroaches, it's said that you can never get rid of cockroaches from a multi-unit building because you may chase it away from the apartment you're looking at, but they'll go away and come back. It's shown that Blacks and Hispanics may be less likely to use mattress covers. The latest EPR4, so to speak, revision of the American guidelines suggests that mattress covers and pillowcase covers are helpful only as part of a combined multi-point allergy protection system. So just using them by themselves really may not have much effect on asthma. You need the landlord's attention, and that may be a public office or private landowner. Other concerns include safety, gangs, walking, how far do they have to walk, how far is a bus stop, how far is school, transportation, private and public, we'll talk about that, and then availability of healthcare and 24-hour pharmacies. In the community where I live, there are 3 CVS pharmacies on the same road, and 2 of them are daylight hours only, and only 1 of them is a 24-hour pharmacy. So I always tell folks they need to find, at least for emergencies, a 24-hour pharmacy. Grocery stores may be a problem in inner cities and schools as well. What's the available health care? What choices does the family have? Do they have SIBs who are already enrolled in an office? What are the locations of the office or an emergency room? And are these offices that a child may be assigned to, are they assigned by the managed care organization, or is it choice? And I've actually had families where my patient was assigned to a different office and caregiver than their SIBs were, which seems to me to make no sense. What are the hours? What are the routine hours? What are the acute issues? When can they be taken care of? What are no-show policies? Are they open on weekends? And that varies from place to place. What are the languages and resources? And does this particular office have good contact with the child's school? What are the spoken languages, written languages, and what's their overall expertise in asthma? What's their after hours management like? And I've been asked when I'm filling out something for a family as an asthma action plan, they ask, is there a charge? Because their primary caregiver charges extra, and it's often not covered by Medicaid for after hours management. There needs to be follow-up routinely. They shouldn't just say, come back when you feel like it. We need to have routine follow-up, and we definitely need to have follow-up after flares of the asthma. And then pharmacies, what's their location, their hours, their language, and their teaching? Do they teach about medications? Do they teach about asthma itself? So continuity versus urgent care. It's important to try to get families to realize that the medical home should be the coordinator of all their asthma care. That sometimes doesn't happen. The referral to asthma specialist is a PCP personal decision. Many decide when you need controllers. That's when you make the referral. Others decide if you have severe asthma and need immunotherapy. That's when they make the referral to an allergist. Fragmented care isn't optimal for chronic illnesses of any type, but especially for kids with asthma. So we have the ER and the medical home, and then we have the electronic health record, which may or may not be the same thing from the ER or hospital and the medical home. There's in some ways too much democracy in that area. Acute flares are potential teaching points that are often missed. I think we have 48 hours of panic after a family spends an evening in the emergency room. And we've really got to utilize that, because a week later, a month later, or at the next well child visit, they will have totally forgotten that. So in order to drive home the risk and the teaching points to indicate why we've got to do the treatment we recommend. Use the 48 hours of panic. And then we need to teach about the therapy we're prescribing and education about asthma and what's the best language to do that. When, as I mentioned before, when a patient's acutely ill, the patient needs to recognize the benefit of the medical home, and the medical home staff needs to be available and helpful. They can't just say, if there's a call, go to the ER. They can have a much more dynamic role than that. And timely communication and coordination through all aspects of care are crucial. So treatment availability, managed care formularies are the bane of our lives some of the time. It's important to realize that there are different pockets for formularies and patient care costs. So the pharmacy versus the ER costs come out of different pockets. It's important to realize the Indian Health Service core formulary comes from the federal government, and the asthma medications are only Singulair, Asthmanex, Advair, Rescue Albuterol, Spiriva, and Prednisone. It's not all that we're used to and would like to have. Smoking cessation products for the Indian Health Service includes nicotine replacement products, bupropion, and varenicline. And that's it again. So there are limitations in the choices. We need to coach how to use devices correctly. We need to teach them how to read dose counters, and we need to use videos and pictures in the clinic and take-home settings. Always use the terms controller versus rescue so that people get it the same all the time. Many folks have steroid phobia. They don't want their child on controllers because they don't want them on all those steroids. But we need to explain that you can take the full dose of an inhaled steroid for over a year, and you get less steroid burden to the body compared to one 5-day course of prednisone. So the inhaled steroids are a tiny, tiny dose compared to the need for prednisone. And remember that the best drug in the world can't help if it stays in the pharmacy. Now let's talk about resource deserts. This means inner cities and rural areas. Caregiver offices for primary care and specialists can be a problem. I did a review of all of the asthma admissions for our hospital several years ago, and of the 3 zip codes that had the most patients, one of those admission zip codes had no primary care or had no pediatricians in it at all. And another one was 3 times bigger in child population, so that's why there were more patients. But anyway, the distribution of healthcare is not equal. Pharmacies vary, and I'll show you some more about that in a moment. Food stores, including fresh produce, are frequently lacking. Transportation services may be lacking. And when you are telling people about choosing housing, be sure to tell them to pay attention to where the bus lines go and the transportation services that they are going to need. Where are urgent care centers? And they may be, in fact, closer than the medical home. For schools, they may have bus rides, but bus rides frequently do not take you to the doctor's office. They may go near an ER or a hospital, but that's a problem. Medicaid and insurance offices for assistance may be far away, and there may be the presence of higher amounts of exhaust and ozone in inner city areas. This is from a fascinating story or article from 2014, and it's a look at various census tract data from Cook County in Chicago. And their question was, what areas have no pharmacy within a half mile? And so an area such as this and here and here and here, there's no pharmacy within a half mile. If you're shaded, there's no pharmacy within a mile of those areas. The green areas are predominantly Black communities. The orange areas are predominantly Hispanic. The red areas are integrated communities, and the blue, what few you find, are white communities. So this shows very dramatically what the situation of pharmacy lack happens to be in Chicago, or was in 2014, in the 4 years before that. And the white tracts pharmacies are available. It's important to document refill histories because parents always say that they take medicines regularly and as prescribed, but when you actually look at pharmacy histories of refills, that disagrees. And I will have very often a family that will say, oh yeah, he gets his medicine twice a day routinely, and yet they haven't filled their controller medicine for 6 to 8 months. And then when I confront them with that, they'll say, oh, well, I tell him to take it. He must not do it. I can't be there every night when he's supposed to be taking it. So they're quick to throw their kids under the bus. Um, and it's been shown in this article from 2009 that non-refills are more likely with new prescriptions. And it's worth remembering that virtually every study that has looked at asthma controller refills for a year, it varies by different device or medication, but they all are somewhere in the 3 to 4 refills per year, where a full year's use is actually 12. So that means they're markedly underusing all of these different medications, and that's a common theme, not just among inner city folks, but in asthma patients in general. There's a program in South Carolina for select health Medicaid patients called NaviNet, and that's a very useful system where the caregivers can go online and get exact refills, and because it comes from the Medicaid payer, it's not, oh, I went to a different pharmacy that time. They get all of the requests for payment from pharmacies, ERs, doctors, et cetera. So if you can find that in your community or with your various providers, it can be extremely helpful. And I would urge that you never consider changing a controller medicine for lack of effect if you haven't checked to make sure they're refilling their meds. Transportation limitations are key. It's expensive to own, run, and insure a vehicle, and there's a requirement for a driver's license. And so if someone is undocumented, they may not feel comfortable going to get a driver's license. When you have limited resources, you're more likely to drive an unreliable vehicle. And one of the things that I recommend to families is that if they ever loan the vehicle to a family member or a friend, they make sure that that person puts gas in the car so that the family doesn't find that all the gas has been used up just at the time they need to go to the ER. There are conflicting needs with limited transportation. Child needs to go to the doctor, parent needs to go to work. The parent for work is going to trump the doctor's visit unless it's ER. And then when you go to the ER, there are worries and distractions that markedly limit learning. I think the ER is a very bad place to try to teach people about asthma because they're worried about how do I get the car back and how is dad going to be able to go to work tomorrow and that sort of thing. And they may have unreliable follow-up from the ER as well. Again, I mentioned about the pharmacies, and buses go to schools, but not the medical home or the specialist or other necessary spots. Medicaid transportation is often available, but in South Carolina, where I live, a provider, a parent could bring the child, but they could not bring any other children with them on Medicaid transportation. So they would have to find daycare or babysitter for the other kids in the family if they were preschool in order to take the transportation provided by Medicaid. What about health understanding? There is a major epidemic of poor health literacy and understanding in the United States these days. And it's estimated to cost over $200 billion annually. there is a program you really need to know about called the Health Literacy Universal Precautions Toolkit, and it involves a lot of recommendations, but one is the teach back method. And with that, it means at the end of a encounter, say, now what did I tell you to do? Or you have your nurse ask the family, what did the doctor or the nurse practitioner tell you to do? Because many families are reluctant to say anything if they're asked, do you have any questions? But if they have to tell what they took away from the encounter, they may be much more likely to reveal communication problems. In terms of education level, we talk about using everyday language or using 4th or 5th grade language. My feeling is that nobody knows that. So I teach residents and med students to not use 3-syllable words. That means if you can express yourself on the fly with 1- and 2-syllable words as the mainstay of your language, you're going to get across to most people. And it's important to realize that literacy in a foreign language can be daunting. And so you want to know, are the medications instructions on bottles and inhalers actually written accurately in the language the patient is comfortable with? And then what is the comfort with written materials? When folks are used to using text message length things, they may have problems or be turned off by a full page of small text. They may have great discomfort saying they don't understand. So we need to figure out the best ways to communicate every patient every time. And Randy Brown, noted asthma professor at Michigan, says that asthma is as much a disorder of communication as it is of inflammation, and that is certainly true. So we've got to communicate effectively not only with the patient and family, but with all the other caregivers. Everyone uses different words to teach, and that can confuse the patient. So as I said, don't use 3-syllable words or larger. That'll help you get away from using medical jargon. And continuity is important for understanding. The more the patient and family can see the same doctor or nurse, the better they'll do. Asthma action plans are important. Dr. Ruchi Gupta in this article developed an innovative asthma action plan for folks with limited understanding, and her goal is addressing literacy level. So the new action plan promotes effective asthma counseling. It's effective with really only slight modifications, and it has availability in multiple language. So we need to remember to have action plans in all potential care sites. So that means not only one for home, but also grandparents, the alternate parent who sees the child every 2 weeks, school, the athletic trainers, etc. Use device pictures if possible, and point out dose counters and then the need for parents to monitor adherence. The SAMPRO program, which is school-based asthma management program, has form templates for you in that regard. It's important to recognize, or to have the family recognize, that they can modify the disease course. Many of our patients feel they can't. You might ask, what experience do they have changing the course of anything significant? And it's sad to realize that the only thing that I could find to talk to folks in general about was face medicine. Generally, people know that if you take acne medicine this week, you're less likely to have your face break out next week. So I tell families that they need to use the controller medicine this week so the lungs won't break out next week. But unfortunate things do happen, and we need to change the powerless victim mentality that a lot of our patients, especially in the inner city, may have. And so they need to know what they do or don't do this week does matter next week. And then you need to demonstrate your availability and your support for them. Chaotic lifestyles are important as a distractor from asthma care. What's most important for the family today? Is it safety, trying to avoid violence? Is it food on the table? Is it having fun? Is it family? Is there another child who's ill? All kinds of things play a role as competitors. Did you remember that appointment or refill? And when you're faced with these sorts of basic things to worry about, you may have forgotten an appointment. And have you had schedules in your existence? If you haven't worked, you may not have had schedules. And so people very often, if they haven't worked, they may not recognize that it makes a difference to come in at the scheduled 10 o'clock appointment versus wandering in at 2 o'clock. And when health coverage has a link in any way to employment, it'll skew the comparative outcomes in the favor of better outcomes when there's private insurance. The concept of future risk or benefit may be lacking. And so, as I mentioned, the acne medicine may help with that. And it's important to realize that, at least in South Carolina, where I am, 41% of children live in a single adult home. That's 10% above the national average. And I think we're the 6th highest in single mom homes. And so that list of stresses and chaotic lifestyle are just made that much worse in a single parent home. What about the age of self-care and supervision? When you have a single parent plus or minus a grandparent, who did we teach to use the device? Is it the grandparent who's looking after the child during the parent's evening shift, and that's when the child gets sick? They often have to ask the child, which inhaler do you use? What about visitation with the other parent? So we need to always coach proper device technique and remind the parents of dose counters. And I tell parents that they can nag the patient weekly and that they should withhold a cell phone or the web access for every day that a teen or preteen misses their controller. If looks could kill, I would be dead 100 times over from the teens who hear me telling their parents that. There are marked variations in ages of self-care. I've seen, but I couldn't find a reference for today's talk saying that in Black populations, the age of self-care may be 8 or 9 years of age, and in the white population, it may be more like 12 or 13 years of age. So that's a huge difference. And so that means who reads our instructions, who knows a refill is needed, and who recognizes a flare. What about the use of schools for care? There, when you have bad asthma, you have frequent absences. And so those schools must have a current asthma action plan. They can provide skilled observation both during rest and during activities. Telehealth programs can be extremely helpful, and we need to make sure that the schools have enough meds and spacers. The nurses, athletic trainers, coaches, the whole asthma team need to be involved, and they can be a source of care and education. They can be especially helpful at finding new patients. I've been told that the surest way to identify new patients with asthma is to ask a PE teacher or a coach who they think is lazy, and that's where you'll find kids with undiagnosed asthma. I mentioned SAMPRO. This is the reference for the SAMPRO toolkit, can be extremely helpful. And then there's critical communication between the school, the family, the provider, the health plan, and the health plan's case managers. Self-care for rescue is available everywhere, but it's something that's a dicey question because it has advantages and disadvantages. When kids have self-care, the parent is less likely to hear that they needed the rescue, but it can allow the child to get a treatment on the school bus. Some patients need provision of controllers at school, and that can be done. I've been surprised by the number of families when I've recommended that they've said, oh, fine, sure, go ahead. I thought they might be insulted, and in fact, they've done very well with that. So Dr. Gupta, who I mentioned before, has the Science and Outcomes of Allergy and Asthma Research Program in Chicago schools, and she utilizes students in their school for student media-based health research team. It's in the inner city schools on the southwest side of Chicago. It does research utilizing education, advocacy, resources available, interaction among students. They have found remarkable student enthusiasm. They've done public service announcements, put up posters, fact sheets, even musical performances. So I encourage you to track down this website and look to see what ideas they can give you for your situation. Asthma coaching is crucial. Asthma education can be done in many settings. It can be individually or in a group. It can be the patient plus or minus the family. You can talk about asthma pathobiology, treatment, acute issues, triggers, those sorts of things. And device training specifically needs to be repeated. Remember, no one would try to coach soccer, football, or cheerleading with just written instructions. And so we shouldn't expect success if we only give written instructions for asthma device use. So pictures can help tremendously, and that includes the poster I'll show you in a second. And then consider obtaining certification yourself as an asthma educator. So this is the brand new 2021 asthma device poster, and I encourage you to have it in every clinic area or area where you encounter patients, and that it allows you to show the which red device they use. Is it a controller? Is it a rescue medicine? All of those, and it also allows you to show where the dose counters are, and so that can be extremely helpful. So you want to support asthma education. Smoking cessation is important. The quit line is 1-800-QUIT-NOW. It's a national program and a very important referral. Include school personnel and link with the schools as much as you can. We want to assure availability of medications and spacers. We need to teach and reteach how to use devices and monitoring. We need to recognize impaired health understanding and attend to that among our families. Use the summer to prepare for back to school flares. Avoid the sick automatically to the ER paradigm, and use family-centered medical health centers as best you can. Utilize lay coaches to promote environmental modification. As I mentioned before, use the 48 hours of panic after an acute flare for education. So personalized medicine allows you to look at an individual patient, not just a typical one. What are the outcome goals? What's the cost versus the need? There's a wide variation in understanding for prescribers, and improving understanding of the disease and the therapy is coming rapidly now. So adherence to prescribed therapy is critical, and to know if a treatment works or not and what you don't get can't help you. You need to recognize and control triggers and comorbidities. And sophisticated lab testing is required for some of the personalized medicine approaches that are coming. So key strategies: give instructions in understandable language, saturate the family with action plans that they can understand, demonstrate correct device usage. Smoking cessation is crucial. We're seeking smoke-free rooms and wombs. Work with the schools, minimize absences, saves money for the school district. That is for help for individualized patients, and as I mentioned, finding unrecognized patients. And then programmatically, we want education in the schools and maintain full activity for patients. So these were the learning objectives I set out beforehand. Did we meet them? If we didn't, include that in your questions to Sally or to me on my email. The take-home message: disparities do exist in asthma. There are many causes and no single fix. Many disparity problems are societal. Who does the family listen to? Do they listen to you? Do they listen to grandma? Do they listen to a website? That sort of thing. There are many misperceptions that are problems, and there may be environmental problems. Coaching is crucial to get past the I can't do it mindset that we find so commonly in the inner city. And we need to recognize individual issues, work with what your setting allows. Don't back away or give up. Be aggressive in trying to serve these patients, and communicate and link to all members of the team. The bigger the team, the more we saturate the caregivers, the better. So what questions do you have? And we have 2 pages of references and a 3 pages of references, and then some relevant websites that I hope you'll be able to go to. So that's it. Thank you very much.
Oh, Dr. Bowman, thank you so much. So we'll start with your questions. And one person's first question is, can you speak to the role of the asthma control test with underserved populations that can help the patient understand whether their asthma is well managed?
The asthma control test is excellent to use. It comes in 2 forms for 4 to 11-year-olds and 12-year-olds and above. And the 4 to 11 has been the most useful to me because the test asks patients and parents to reflect back on the last month as to degree of symptom appearance. And what we see is that the kids answer 4 questions and the parents answer 3. And I'm always amazed when the child says they're really not doing well with exercise, and the parent will say, "I didn't know that. I had no idea." And the child will say, "Well, you never asked me about it." So it's crucial to use the asthma control test while they're waiting to be seen. Make sure that the child fills out their questions and the parent fills out their questions. Don't get into the habit where the parent just fills out all 7 questions, because we gain information from the child as well as the parent.
Oh, thank you so much. A follow-up to that question is, what frequency for the ACT do you suggest?
We use it with every encounter. So I guess if you saw a patient 2 weeks ago and now you're seeing them back because they were sick, it may not be so helpful then, but we use it every time we see the patient. And I think for routine follow-up, as a specialist, we would see patients every 3 months. I think primary care folks generally figure they need to see patients every 3 to 6 months, certainly not just once a year.
Okay, great. Our next question is, what are you doing differently now with COVID? And also, is there anything that can be done virtually to take care of this population?
There's a lot that can be done virtually. Since I'm retired, I have not had to struggle through keeping a clinic going and patients current during COVID. But most video encounters don't include a stethoscope. Our statewide electronic medical program for remote care includes schools having electronic stethoscopes and that sort of thing. So you can actually listen to a patient. But when you're doing a remote video, a Zoom call with a family, you can hear if there's breathing, that is, if they're coughing or wheezing, but you can't really hear airflow. But you can see the degree of distress. And so you can do that. It's better than nothing. I think that you certainly aren't able to do spirometry, although most primary care offices, I don't think, currently do spirometry. You can get a history. You can try to find out about how the family seems to be doing. Depending on how far in advance you know you're going to have a visit, you can check with the pharmacy about refills and that sort of thing. So they're better than nothing, but it's not as good as in person, I don't think. As far as COVID goes, I wrote a series of FAQ questions and answers related to COVID, and I think those are on the AAN library listing at this point. Anyway, the main thing is to follow the asthma action plan and be meticulous in the care. It was originally worried that prednisone would be a problem. It turns out that while nebulizer treatments are generally still, I think, withheld as much as possible as a potential spreader of COVID, MDIs and spacers don't seem to be a problem in that regard. And there's even suggestion from a couple of sources that inhaled corticosteroids increase the amount of binding sites for COVID, so it may be protective to have the patient getting, no, it decreases the binding sites, not increases, decreases the binding sites. So the virus isn't as able to spread in the lungs of someone who is routinely taking their controller medicines.
Oh, thank you for that. And just an aside is that Allergy and Asthma Network has a telehealth asthma education program through our Trusted Messengers program in an effort to reach people in disparate communities. So if you need more information about that, you can certainly check in with us about that. Another question is, many underserved children do not have an asthma action plan. What should a school nurse do in that situation?
Be pushy, pushy, pushy. And it is exceedingly frustrating to either get no action plan and therefore no medication, and to get one that says 2 puffs of albuterol every 4 hours and that's it. Because when that's not enough, the ambulance trip is the next thing. And so usually I think you need to go to the parent and say, you know, I'm really having difficulty getting the action plan from the doctor or the office, and ask the family to go to the office and get the action plan and the additional prescription to bring in the medications that are necessary in the spacers, because it is a major issue. We had set up here in Charleston with the school district that we could use the fax number for the health office of the district, so that the prescribers didn't have to know the specific school that the child was attending. They could send it to the school district health office, and then they would distribute it to the schools. And so that may be something you want to try to accomplish in your own school districts.
Sounds good. Well, the next question is one that I should answer. The question is,
Please
can we
do.
PowerPoint slides for this and last week's seminars? And the answer is yes, they are. The PowerPoint slides will be posted on our website with the recording of the webinar. And all of our recordings from our webinars are on our page. Go to allergyasthmanetwork.org, go to news, and go to webinars, and you'll find them there. And Dr. Bowman, our last question is, would you do anything differently if working out in rural areas with medications and care?
Probably not. I would probably try to link up with schools even more closely, and I would be looking a lot more for outdoor type triggers. And I would have hypersensitivity pneumonitis as a mimic to a greater extent than in the inner city. But the same history, look for triggers, look for comorbidities, educate, and try to make sure that the family really does have access to their pharmacy. Nowadays, a lot of pharmacies will deliver their medications, and so you may want to use that in a greater extent in a rural population. But I think those are the main things. There are those who say that the down and dirty play in the yard approach minimizes asthma severity, and that part of the uptick in asthma comes from our cleanliness and our immunity. And so I think that encouraging activity outside and just watching for inhalation triggers and such is probably a wise thing to do.
Oh, thank you so much, Dr. Bowman, and thank you for being with us today. We appreciate your commitment to asthma care.
It's my pleasure.
And I'd like to thank our listeners for being with us today as well. Allergy and Asthma Network has a valued community asthma and COPD experts program. For more information on that program, please visit allergyasthmanetwork.org or email me at sschessler@allergyasthmanetwork.org. Thank you again for joining us. This is Sally Schessler for the staff at Allergy and Asthma Network. Join us as we work together to improve health outcomes for each person so we can all breathe better together.